Doesn't love me.
Maybe, sir.
Good afternoon. Welcome to the meeting of the Health and Wellbeing Overview and Scrutiny Committee on the, what's the date today, 31st of May. Just to remind you all that this programme is being live streamed and people can watch it on the Northumbria's YouTube programme. Can I remind you as well to either switch off your mobile phone or put it onto silent? Sorry, that wasn't aimed at you, it was just on my notes, and to put it onto silent. Thank you. Right, so and I'd like to also welcome Councillor Chicken to the meeting, attending her first meeting of this scrutiny, so welcome. So the first item on the agenda is, because this is the annual meeting, is the membership and terms of reference. So as a committee, you're asked to note the following membership terms of the following membership and terms of reference for this committee, which were agreed by the Council on the 4th of May 2022. I think you just asked to note that. Is everybody happy with that?
Agreed.
Yeah. Agreed, right. Apologies, I have no apologies for absence, and it appears to me that everybody's here. So, thank you. Minutes. We've got the minutes of the Health and Wellbeing Overview and Scrutiny Committee from the 5th of April. Can they be confirmed as a true record and sign them?
Move accept.
Thank you, Councillor Hardy and Councillor Hunter. Yeah, thank you. Disclosure of members' interests. Does anybody have any disclosures to make on any items on this agenda? No. Okay, thank you. Primary Care Applications Working Group. The committee is also asked to confirm the membership in terms of reference of the working group, which comprises 4 members, including the Chair and Vice Chairman of this committee, plus 2 other members. Current membership is Councillor Nesbitt, myself, and Councillor Bowman and Councillor Hunter. Is everybody happy with that?
Happy,
yeah, no objections. Right. Also, to note that the monitoring report of the Primary Care Applications Working Group are included in your agenda pack. So the monitoring report goes at the moment to the CCG and will in future go to the new Integrated Care Board at the ICB. I didn't want to say ICB, so I wanted to say the word and then I just wasn't sure. So that's it, thank you. Forward plan. So item 6, the forward plan, to note the forward plan for key decisions. I can't see anything, there isn't anything that affects this committee. So move on. So the next one is the report of the Interim Executive Director of Public Health and Community Services to give us a progress report on the 0-19 Section 5 Partnership Agreement with Harrogate and District NHS Foundation Trust. So we have Liz Morgan and we have Suzanne Lamb, who's from the Harrogate and District Foundation Trust. And you're going to, can I just pass over to you now?
You can indeed, yes, thank you. So you've got the report there and hopefully you've had a chance to read it. I'm just going to provide you with a bit of sort of background and cover the way that the partnership is currently governed. And then I'll hand over to Suzanne to talk in a little bit more detail about some of the areas that we've been working on since October. So you'll recall that last year we saw the dissolution of the Section 75 partnership agreement that we'd had in place with Northumbria Trust for some time. And as a result of that, we had to obviously establish alternative provision for the services that were part of that partnership agreement. And one of those services was the 0-19 service, which provides a range of services, including health visiting, school nursing, and a whole spectrum of other specialist staff who are there to support children, young people and families. Some elements of that service are a statutory responsibility of the local authority, but all of it is funded through the Public Health Ring-Fenced Grant. So our preferred option was to seek another provider with whom we could enter into a partnership arrangement with, and as that required formal consultation, it came to overview and scrutiny last August. As part of that consultation process, and ultimately the partnership agreement started with Harrogate and District Foundation Trust on the 1st of October 2021. So the partnership itself is actually managed by an officer-led Healthy Families Partnership Board. So that incorporates senior officers from both the Trust and the local authority. It's now actually chaired by myself, and it meets every other month and focuses on some of the key issues around delivery, but also looks at more strategic development work, and at the moment that really revolves around the integration of services supporting children and young people. And I think we've got a real appetite across the local authority and the Trust to become an example of what good looks like. I think the key successes for me are that we've developed some really excellent working relationships with Harrogate and District Trust colleagues. We landed the service safely in a very short period of time, and I think the wealth of experience in delivering 0 to 19 services that Harrogate brings is really improving this service for children and young people. So I'll hand over to Suzanne to just talk in a little bit more detail about some of those key areas that we've been working on since October.
Hello everyone, my name is Suzanne and I'm Head of Nursing and Head of... Yeah, it was really about ensuring that we had a safe lift and shift of this service over. We normally have a much longer period of time to transfer services, and so what we really wanted to make sure was that staff felt safe, they had their clinical record keeping via IT available to them, and that they were going to get paid. These are the really important things that make sure that staff feel secure in their employment. We did that worked well, and then we started looking really at the service and what clinical transformation was required. What we then had to put in was the HDFT, or the Harrogate HDFT governance processes. We have really strong governance processes which ensure a safe service, but also ensure that we can report on the activity. To a certain extent, I think that was a bigger piece of work than we expected, and I think it's been fair to say that the service maybe didn't have the robust governance processes in place that we maybe would have expected. So that's been quite a big piece of work. You may remember that when I met with you last year, one of the things I talked about was every member of our staff has a monthly one-to-one, which includes a wellbeing conversation. It's really important that that was implemented and done. Also that we had really strong, robust communication to ensure that every member of staff is kept abreast of what's happening all the time. This, of course, done at a time of lockdowns, changes to those arrangements, etc., which can cause some difficulty. I think it's fair to say that we moved all the staff into uniforms. That was high excitement. They hadn't worn uniforms before, proved to be very popular. We've had really positive feedback on that. One of the priorities that we did, as my role is Head of Safeguarding for the Trust, was we very used and very experienced in delivering safeguarding practice in a 0 to 19 service, and we know what works well. So we carried out an audit on the safeguarding roles within the 0 to 19 service, particularly in 5 to 19, and that has been a key area of transformation, to make sure that when we take part in safeguarding, when we provide in that service, we're doing it in a way that makes the most impact on outcomes. So that has been a key element of the transformation. And the audit didn't produce any surprises for me. It was in line with what we've seen elsewhere. We've had a few problems with estates. Those estate problems would have happened no matter who the provider was. Very shortly after we took over the contract, a GP practice served notice on that estate, which means we've had to work really hard at finding alternative premises. And despite a real appetite for the county council and ourselves to work together in a co-location, there isn't actually the space in the local authority buildings, so we having to find alternative accommodation, which I have to say is proven much more difficult than we expected. But we are moving along in finding alternative accommodation. Key to the governance processes is having all the systems and processes in place in which we could provide reports, provide assurance on performance and on activity. And that requires a complete overhaul of the system one, that is the electronic record keeping processes that we have. What we inherited when we inherited the Northumberland units were unfortunately not quite at the standard that we required, so we are having to do a complete overhaul of those units. That doesn't mean to say we can't provide the reports, and we're still doing that, and we haven't seen any dip in activity or out of line with any of our other contracts. So COVID and the pandemic has affected some face-to-face contacts, but Northumberland is not an outlier on that, and what we've seen is a sustained growth in activity. What's happening next? We, as I say, we really concentrated first of all on the lift and shift, safe transfer of staff, and then ensuring that we implemented our governance processes. We're now moving into a stage where we are looking at a restructure and a movement towards the clinical transformation of the teams. So that restructure will start on the 6th of June. So I'm leading on that on behalf of the Trust. That's a formal consultation with the staff. We're not looking at any redundancies. We're not looking at any staff losing their jobs. All we are looking at is ensuring that we have a service with roles within it that really is built for the future, and looking at a modern 0 to 19 service. What we inherited was a 0 to 5 service and a 5 to 19 services, which were managed very, very separately. So that's health visit and managed totally separately to school nursing. That is not the way to manage an efficient 0 to 19 service. So we're amalgamating that to be a 0 to 19 service, and we are looking at new roles which are around building partnerships, ensuring that we're working together with partners and developing integrated service pathways, which is better for the service user, but it's also ensuring that our staff are working in an environment with key partners, which is really driving change for children and people, which has impact and outcomes. So we're really pleased to have inherited a service which was high performing. We can absolutely give assurance that that service has continued to be high performing, but we are looking at making service improvements and modernising the service, and that will happen within the next few months. So I'm here to answer any questions that anyone may have about HDFT or the 0 to 19 service in Northumberland.
Thank you very much. Committee got any questions? Councillor Hill.
Thank you. It's an understandable report at the stage where you're at. There's not much for us, I feel, to scrutinise on this or really get a grip on how well the new service has been implemented and the changeover. So it's difficult to know where to begin. But just one thing, on page 25, you mentioned the Audit of Safeguarding. We haven't got a copy of that audit or a summary. Is there anyway, I know that some parts might be redacted of other reasons, but it would be good to have more details of that actual audit.
That
Scrutiny
audit has
purpose.
been presented at the Children's Safeguarding Partnership, so
Right.
the detail of that audit are available through the Children's Safeguarding Partnership.
Right.
But we can, I mean, if that would be helpful to the group that can share that, I can summarise the outcomes of that for you. It's not that it would be redacted, it doesn't contain personal
Right, okay, so
information or
we
anything
should-
like that. This is a retrospective audit that looks at, particularly in 5 to 19, which is the school nursing service, which particularly looks at the impact and outcomes of that school nurses have had on safeguarding cases. And what we have found is that the school nurses have, without exception, in the services that we deliver, have got caught up in the bureaucracy or the administration of safeguarding rather than on actually delivering therapeutic interventions which have an impact on children and young people. We don't have the evidence for that without doing a retrospective audit. So that audit has been carried out now in Northumberland, and we have found, exactly in line with our other services as well, that what we could not effectively demonstrate is historically, when we look at children who were on a plan 12 months ago, we look at the impact and audit that the school nurse has made on that family, it's minimal. And that's because they've really been spread too thinly in terms of joining in that bureaucratic process. So our model going forward is to make sure that the school nurses are involved in the right families with the right children where they will make a difference. And that through working together, what we actually need through working together is that health is represented at meetings, such as strategy meetings, ICPC. Historically, health is equated to school nursing, whereas actually it's about having the right health professional sitting round the table to influence decision making, and not always the school nursing service. So those are the changes that we are making. We presented the outcome of that report to the Children's Safeguarding Partnership at the April meeting. Yeah.
Any other Councillor Hunter?
Thank you, Chair. As usual, when you get any changes to services and that, have you had any complaints from either the service users or staff? Because often, we're all very similar as to if there's changes, have you felt that, or has you felt it's reasonably smoothly moved across without too many complaints?
There hasn't been a lot of complaints. I think initially service users may have been concerned when they hear the word Harrogate that this is quite remote, and that they can't really relate to that. They then see that when the service is delivered by the same people, the same health visitors, the same school nurses, it's their employer that has changed. It doesn't change the service they receive. So I think people find that reassuring. In terms of staff, if I'm honest, I think there's probably, in any staff group, you will get a percentage of people right at the top who are really willing to change. You'll get a percentage of people at this end who are not very willing to change, and then you'll get the vast majority of people who will go with the flow. And that's probably what we've found.
That's good news.
Thank you. Any more questions? Derry.
Thank you. Hi, I'm Derry Nugent from Health Watch Northumberland, and I think we had an email exchange yesterday,
yes.
so thank you for that. My question is really following on from Councillor Hunter's, which is, you mentioned service user experience as part of your quality framework, and I just wondered if you could say a little bit about what that comprises, because as you say, I think people's first, patients' first view and parents' first view is, oh, Harrogate, what's that about? How do I raise issues? Now, obviously we would like them to raise them through us, but it's how we can then pass it on to you. So if you could say a bit about how your service use experience works and how you gather that.
Right, so we, as part of the positive nature of having a trust that provides a lot of 0 to 19 services, is that some of the work that needs doing can be done not just by Northumberland, it can be done by the the wider footprint. So we have a senior manager who leads on gathering service user experience. We do that through a variety of methods. So it may be through surveys, SurveyMonkey, for example. We've developed a digital approach to the Friends and Family Test, which is much bigger than the Friends and Family Test, which is a little bit limited. But in the digital offer is a bit wider than that. We look at complaints, we look at feedback, service feedback that comes in through maybe through incidents, etc. There hasn't been an increase in complaints in any way, shape or form. But what I would say is some of the things that we would use in order to gather service user feedback are not yet embedded in Northumberland. So, for example, we have an app, which in some of our other 0 to 19 teams is we've now got really widely used. So the use of social media, the use of digital platforms, a website, an app, all of these things that are things that we have, which we are putting into Northumberland, but they're not available yet. We're still working with the team to get those in place. We then have a service user experience group across the footprint that all feeds into that group, and then we produce those reports. Those reports go into our commissioner meetings, into our contract meetings, and they will form part of a qualitative element of that report. So service user feedback is part of the quality improvement cycle.
But as you say, that's developing in Northumberland.
Yes, because they didn't have any use of social media at all, and actually that was one of the things that the staff were very, very keen to do and learn from us. So that's something that we're having to put in. You know, we're developing an app for Northumberland that has to be Northumberland local, you know, so that takes a little bit of time to put in, but those things are being put in.
That's good to hear, because obviously you've given me now the name of someone to contact.
Yes, I have.
So we can flow information
Yes.
to you, which I think is going to be really important, because obviously then that can flow into all of your reporting further
Yes.
up. So thank you for that.
Thank you. Is there any more questions? I've got just a couple. Could I just ask, there's two things really, is the 0 to 19 family partnership, but Healthy Families Partnership Board. I just wondered how that fitted into the Health and Wellbeing Board. And the other question was, in the report it mentions about the recruitment and retention, recruitment and promoting vacancies. How are your staffing levels? Have they been maintained through the changeover?
So I'll answer the first question. So the Healthy Families Partnership Board feeds into the Children and Young People Strategic Partnership, and it's the Children and Young People Strategic Partnership Board that should feed into this, or should feed into the Health and Wellbeing Board. But actually, what we've realised as part of this work that we want to take forward around children and young people's integration is that we have got a whole range of different groups looking at different bits of service pathways. So Graham Reiter is currently doing a bit of work to actually just completely review the governance arrangements that we've got in place. But at the moment, the Healthy Families Partnership Board links into that strategic Children and Young People's Partnership Board.
Thank you.
In relation to recruitment, there is a national shortage of specialist public health nurses, which includes health visitors and school nurses. So we have had to look really imaginatively at how we address that issue. It's true to say that actually when we compare Northumberland to our other areas where we provide this service, it actually doesn't compare very well. I'm afraid that we have more vacancies in terms of the health visit. This is what we inherited. It hasn't happened since then. There's quite a high vacancy rate. I think that's because geographically there's a level of isolation in Northumberland, plus in Scotland, where of course we've got a border. They pay on a higher grade, so I think that has an impact on recruitment into this area. However, what we are doing is looking at an internal development programme. So you employ staff nurses, which are a band 5 role, and you develop them to move into skiffing roles. So what we will do is employ people on a 5, we will put them through the skiffing training, which trains health visitors or school nurses, and then we will employ them within that role. We also are looking at other roles. So, for example, in safeguarding, you do not need to be a health visitor or a school nurse to work in safeguarding. You can have transferable experience. So we're looking at all our roles and making sure that whenever we can, we don't just rely on that limited workforce, but we also have development roles where we do need that workforce and how we can move them into those roles.
Thank you. Questions? So we do have some recommendations. So we're recommending of this report and comment on the delivery, which I think we have done. So I think we completed that, yes? Yeah? Okay, so thank you. So thank you, Liz and Suzanne. You're very welcome to stay for the rest of the meeting, or if you've got other things to do, we're happy to excuse you. So thank you very much for coming.
Okay, thanks very much.
Okay. Let them go. So we have the report of the, is that right? The interim Executive Director of Finance and the Interim Director of Adult Social Services, which I think is the Director of Adult Social Services, yes, Neil Bradley. So it's the financial implications at the end of the partnership with Northumbria Healthcare. Neil, will you take us through it?
Yeah, thank you, Chair. I'm more than happy to take you through it. I must admit, just as a point of overview, when we were putting this report together, I mean, I have to say this was probably the most challenging 10-month period of my entire 30-year career that we went through, from around about January, February 2021 to the separation from the Trust in October 21. And to fit that into 4 pages here didn't seem to quite do it justice, but I know we are focusing on one specific aspect of it predominantly, which is the finances. So I'll run you through it, but with a bit of context as well. I mean, the first couple of pages have a little bit of an overview. I mean, clearly, it was a direction of travel that we had to go down at the point that decisions were made, and we were a bit worried about how staff would respond to that within the adult care service itself. There was an awful lot of disruption over that period. I mean, obviously, I was coordinating large chunks of it, but for everybody involved, 2P is quite a stressful process to go through for staff, and that level of change is quite stressful for them to go through. It's been really pleasing to say we're only 6 months past that deadline, but broadly the feedback's been really good from staff. I think people have moved their heads to the positive side of this. There were many positives to being in partnership with the Trust, and there are positives to not being in partnership as well, some of which we'll touch on in the second paper that I'm going to go through, because these two papers are linked. But broadly, the staff have been quite welcoming of it. It has actually solved some problems for us as well. As I say, I'm not being disparaging. I mean, I worked in the health service for the best part of 13 years as part of this partnership, and we achieved some amazing things, but some things were difficult. I mean, because all of the facets of adult care social work are managed through local authorities. When it came to recruitment, it could be difficult to recruit social workers because they were having to step out of a local authority environment into an NHS environment. You know, we haven't got that problem now, and it's easier for staff to move between local authorities and things like that. So, glass half full, that there have been benefits from this that we are looking to take forward. The report also recognises the massive contribution that was made by the Council's corporate functions. I mean, HR, IT, estates absolutely knocked doors out of windows for us to help us get this over the line. And I think it is important to recognise that. I think IT and HR in particular had as torrid a time as I did for that period and did some amazing things with us to get this over the line. And as I say, that paragraph 5 within the report just starts to touch on some of the structural changes that we've been able to implement, but I'll hold my fire on that one because it is the bulk of the second report that I'm going to go through today for you. If we come back to finances, I mean, remembering that we went into partnership with the NHS, not Northumbria Healthcare Trust, but the NHS way back in sort of 2001, 2002 at the inception of the Care Trust, we've broadly had 20 years of integrated working with them and all the complexity that goes with that. We moved to the partnership with the Trust in 2011 when the NHS changed structure, so we'd had a good 10, 11 years with them at that point, and there was an awful lot to unpick in finance terms because it had been a very mature relationship that we had. It wasn't a relationship based on counting every penny that was going through. There was a lot of flexibility within that relationship, and there was a lot of maturity shown, I think, by the leadership teams of both organisations to if it was predominantly the right thing to do for the residents of Northumberland, the joint body moved ahead with what they were trying to do and didn't worry too much about whether it was £1,000 here or £1,000 there. But when we came to unpick that, although we knew there was a quid pro quo on both sides, it did become very complicated at that point. I'm a classic example. I was employed by the Trust at that point in time. My salary was genuinely paid 50% by the NHS and 50% by the local authority. If you don't have a partnership, I have to end up on one side or the other, and therefore the bill for the other part of my salary moves with me when I go across. And there was a lot of unpicking of that to do across different posts, different structures and different responsibilities that were going on in there. So kind of paragraph 1 mentions that, and I will, unusually I don't normally go through line by line detail, but I will just touch on the table on the second page briefly when I get down to that. But there was a lot of unpicking of posts and there was a lot of complexity around that movement between the two organisations. The big problem for HR is we had all of the staff mapped into the NHS agenda for change salary points and positions which don't exist within a local authority. So at the point that the staff moved over, you couldn't pay them the same level effectively that they were being paid in the NHS. They had to map onto local authority, grades, salary points and scales. Clearly some staff won slightly out of that. They did slightly better when their grades were assessed. Some stayed broadly the same and some were graded at a slightly lower level but have been pay protected on as they came across. So we had a lot of disruption around that and some financial impact off the back of that as well. And the other really big issue was probably pensions. We have benefited for the period we've been with the Trust from 2019. The NHS pension contribution increased quite significantly for NHS bodies. It went from 14.4% to 20.1%. But the NHS was protected from that by central government. So they've had several years of transitional funding, and we reaped the benefit of that transitional funding because we were part of the NHS at that point. There was a concern when we exited, even though we were petitioning to try and keep the staff in the NHS pension scheme, that we might immediately be hit with that 5% increase in cost for pensions. It hasn't worked out that way. We've ended up with a 2.5% increase, but we've kept some of the transitional protection, so we haven't been hit with the full bill. Again, the contract for every other local authority, they're paying the LGPS pension scheme rate, which is already sitting at 21%. So again, it was a win while we were in partnership. But it just puts us closer back to a baseline position with what other local authorities have had as a cost structure all the way through. I mean, I will take questions at the end. I know some of this gets a bit complicated in terms of where I'm trying to keep it as simple as I can. It's probably easiest if I just flip over to the table and just take you through the main headlines of that. And I will just dwell on it for a second because some of the line titles are possibly a bit difficult to interpret at face value. So the top line, cost of existing posts transferring to NCC terms and conditions, that was what I explained before. That was some staff when they were job evaluated on the council scales coming out at a higher level than they were on the NHS scales. And there was a small amount as well of levelling up. It became clear when we moved across that staff in some services, particularly children's services, which is the closest match to adults, were being paid at a higher level than the adult staff were in the Trust side. So we've been able to eradicate some of those differentials, but it did have a cost implication that came with it. The next two lines are the movement of posts that I described. So line 2 there, and when I mentioned that half of my cost was paid for by the Trust and is now paid for by the Council, that comes out in line 2 as an additional cost to the Council. But line 3 below shows that there was a lot of posts that went over to the Trust side as costs. So net overall, the Council has handed more posts across in cost terms to the Trust than it's inherited moving to itself. But as I say, there were an awful lot of kind of combined roles and things like that, so that's why that movement is so big. The additional pension costs are shown on there as a scenario A and scenario B. cost implications. Scenario A is what has actually played out now, as the additional cost to the council of the pensions I described before. Scenario B will be what happens when the transitional protection eventually ends. But worth bearing in mind, that will hit every NHS body as well at the point that that protection ends. It won't just be an issue for Northumberland County Council, as it still has staff within the NHS pension scheme. The next block is a few bits and pieces of costs that came through, the biggest one being IT licences and contracts. All staff, like myself, were on the Trust's networks, we were on the Trust's systems, we were on the Trust's licensing, and the councils had to pick that up for 600 to 700 staff that transferred over. So there's obviously an ongoing cost to that. And then the block below that is additional support staff that were needed because the Trust was doing all HR, it was doing all payroll for 600 to 700 staff, and our own corporate functions needed to be boosted a little bit to cope with the marginal addition of those staff falling under the council's responsibility again. And then the bottom section of that report just shows some one-off costs that were incurred. The bulk of them were around IT equipment and migration costs. I don't have more detail on that here, but I can get more detail for OSC if they want it. But there's a scheduled breakdown from the IT team on what comprises that. But some of that was consultancy around the transfer. Some of it was paying the Trust as well for them continuing to provide some support after the point of exit to give our IT functions enough time to be able to get everything mapped across for the staff, etc. So, as I say, quite a short, punchy report, focused on the financial outcomes, which we always asked to provide. But I'm more than happy to field any questions if anybody's got any at all.
Thank you. The report is actually for information, but it's important still to ask questions and make comments. Well, I just wanted to ask though, Anil, are you happy to take the questions and comments on that section? You don't want to run the two together?
I mean, it probably is worth pausing because there's so much finance in there, but if it's about restructure and frontline teams, I've got another report, the second report covers that.
So I think that's what I was going to say.
Yeah,
so
thanks, Chair.
Questions and comments, but on this part of the report, please. Councillor Dodd.
Yeah, Councillor Jones and I were ringside when all this sort of kicked off a while ago, when we had the Trust who said, no, we don't want to continue. And I think at the time it was estimated to £2 to £2.5 million would be the cost of the transfer. So, I mean, while, virtually spot on at £2 to £2.5 million, depends on how you look at that, with option A and B. It's just a shame that this has happened. We've had no control over it. It was two partners and one pulled out, and we had the problem. So that's 2 million plus just gone, and that's a shame because that is gone. That's money that's come in and gone out, and it's now disappeared into this project. Although you do say there's some positives in there where we've tidied things up. I just hope we learn some lessons from this. That if we go into partnerships again with anybody, we have to have caution. That's all, Chair. Not really a question, just a comment that you were on the money and you haven't gone over. Thank you.
Councillor Hill.
Yeah, I was just going to ask, and it may be something that will come up next week, but it was obviously the partnership with Northumbria Healthcare that led to joint employees, people paid salaries, half with the healthcare and half from NCC, and led to sort of expertise that was sold under the international consultancy business, which a Section 114 notice has now been issued. So I was just wondering, and suggestions of unlawful expenditure and so on, what are the implications, if any, for that notice on for the Trust, basically? Because obviously they're implicated, it's the wrong word, but they were obviously heavily involved in it. It was that partnership that led to the selling the consultancy services. So I don't know if there's any you can comment on the implications because of what's happened with the council.
I'm not sure that's a question we can actually ask Mr. Neil Bradley, but
it might be one that will have to come up next week, but I just wondered if there's any, now we're looking at the whole financial and then the partnership, there could be some even litigation, there could be some repercussions because of that, and I think that's fair enough to ask. You might say there's none, you might say you don't know yet, you might say it has to, you have to ask that next week, but I just wondered if you wanted to comment.
Yeah, no, I mean, happy to come back on my knowledge of the way the legal arrangements work around both organisations. So I wouldn't want to answer that specifically about international, but it is quite clear in legislation that a trust has greater freedom in terms of its ability to conduct business, so long as it makes profit from that business and that profit is invested back in the healthcare of the community that it's or the purpose that it's serving for that community. Local authorities are more tightly governed by the Local Government Act in what they can do around when they can and can't develop businesses outwith of their core function. So I suspect, but as I say, I'm not giving you a legal position here, that the Trust would have far more flexibility in terms of its approach to different situations around investment in business. I mean, it's no secret the Trust runs a car leasing function. It's recently started, I believe, a PPE manufacturing function out in Seaton Delaval. So it has degrees of flexibility. None of that's been done through an arm's length company, to the best of my knowledge. It's done through the core trust structure.
Thank you, Neil. Councillor Hunter.
Thank you, Chair. Just on the finance of the 2.5 million, on 1.4 is included in the budget this year. Are you comfortable that, you know, there should be enough within the budget? And nobody knows at this stage in the budget year, things can change, but are you comfortable enough that you think it could be the right figure?
Yeah, I mean, we've been working with corporate finance all the way through. So in terms of the impact of the ending of the partnership agreement, we're happy that what has been done through the budget setting round is appropriate for what we needed. I think our worries about the budget would be more the savings targets that have been put on adult care in relation to commission services and things like that, which are going to be more challenging to achieve. So yes, thank you.
Thank you.
Sorry, any other questions? No. In that case, Neil, can we ask you to take us through the second report, which is the integration of adult social care with the NHS community-based services?
Yeah, more than happy to do that, Chair. Yes, so this is a really positive development for adult social care as an organisation. So during way back in 2019, pre-COVID, we, as senior managers within adult care, had a realisation that perhaps what we'd been trying to achieve in terms of structure and direction of travel over the past sort of 4, 5, 6 years hadn't quite got us to the position where we hoped it would get us. And I'm not in any way being critical of predecessors' attempts to try and modernise the service. In fact, the direction that we were trying to travel at that point was being well touted nationally as a good model to operate from, based on functional specialisms within services and trying to get efficiency out of those specialisms. In layman's terms, broadly, what we had at that point was quite compartmentalised teams. So you had social workers all sitting together in one function, you had care managers sitting together in another function, you had OTs sitting together over here. So you had blocks of staff who were doing the same thing. And the idea is those staff fed off each other, undertaking similar tasks, enhanced their skills, and you had economies of scale in what you were doing. Clearly, complex cases, new cases would go to social workers once those cases were settled down and people were had packages of care or were stabilised in position. They'd move to care managers to be looked after in the longer term. By 2019, what we were recognising was this perhaps wasn't an optimum journey for the client, though. It might be very efficient for us to operate an organisation this way, but when you actually looked at it from the client's viewpoint, they were being handed off between teams, they were having to tell their story multiple times to different members of staff. We already have this function between different parts of the NHS potentially and moving across to local authorities, and actually within the local authority, we were potentially making that worse. Now, that's not to say we didn't have some brilliant experiences for people. I'm generalising here, but we just thought this probably wasn't the optimum way that we wanted to manage services going forward. And actually, it moved away from a model that we'd had in the mid to late 90s that had enabled much better integration with parts of the NHS than we'd had. And by the NHS there, I mean primary care and mental health services, obviously, rather than the Trust, who we were fully integrated with at that point in time. So, as I say, through 2019, we consulted widely with teams, we consulted with other bodies, and we decided that we wanted to change the model. We would have liked to have moved ahead with that through 2020, but COVID did decide to come and put a bit of a spanner in the works. And then as we were coming to the back end of COVID, we wanted to move ahead again, and then we had the dissolution of the partnership, which I've just mentioned in the previous report. And quite rightly, I mean, I don't criticise the trust in any way, shape or form. As they were going through that level of separation, the last thing they wanted was us doing a major structural change of staff at the same time. Although I would submit our preference would have been to do the two together and just take staff through one big exercise at once. But I understand why the trust didn't want to do that, and I respect their view on that. So really, we haven't been able to start to action this until we actually left in October. So as soon as we separated in October, we moved ahead immediately to try and implement this. We started consultation with staff, which I have to say was probably one of the easiest consultations I've ever been through, because staff have fully embraced the direction of travel on this and have seen the benefit from it. And what we've decided to move towards is what we've called here in paragraph 1.5 a care and support function and care and support teams that are closely aligned to primary care and the PCN network. Remembering these deal with the elderly, the frail, and people come through with relatively low-level mental health issues. Primary care is your key NHS body that you're dealing with there. That's where you get a lot of your referrals from. That's where, if you've got the interface working very well, as we did have many years ago with integrated teams, you can really make a big difference in kind of intercepting issues early and potentially them not getting as far as they were doing in the system that we were operating before the point of change. And then on the other side, our specialist teams, so our learning disability and mental health teams, again, a similar model. We're working along mapping them to primary care networks and GP practices, but also closely aligning with CNTW to try and recreate some of the joint working that we had that sadly did move apart during our time with the acute trust. I mean, I think it is difficult for the NHS, you know, and particularly at that period, they're huge bodies, the structure is really complex, and actually they're technically in a competitive, or they were in a competitive environment bidding for resources against each other, so it is quite difficult. And I can see why CNTW, when we were part of the trust, would have found that more difficult to try and work with us on. One of the advantages of us separating is we are in reality masters of our own destiny now in terms of who we integrate at what point. We still have excellent integration with the trust on hospital discharge, but that's the key interface that we have with them. We can now redevelop services with CNTW, and actually there's been some really positive conversations since October onwards with the managers there. At the point, we've already gone ahead with our restructure. We went live with this on the 1st of April. CNTW is looking at restructuring its teams at this point, and we are closely talking to them about what they're doing in case we want to tweak our structures and that they can link into us so that we get things as kind of close together as we can get them. I mean, the report goes through in quite a bit of detail what I've just mentioned in overview there. So, I mean, it talks about the PCN groupings on page 5 and the fact that we've got 14 care and support teams linked to those groupings. Those teams are made up at this point of care managers and social workers combined. We're not going to physically co-locate necessarily with the GP practices, which we have had at some point in the past. I think the world's moved on through COVID, and with hybrid working and things like that, we're not entirely sure co-location is both a necessary model and a desirable model, because it may reduce the flexibility of staff to some degree, but nothing's off the agenda at the minute as we look to bed this in and to kind of move forward with it. So we might well come back to co-location and talk about that, but in actual fact we're running virtual multidisciplinary meetings with different GP practices now. They're going really well, and obviously we'll pick that up going forward. On the specialist teams and the CNTW side, it's a similar story there. We've got 6 community mental health teams and we've got 4 learning disability teams. Again, aligned with the PCNs. The staff numbers are smaller, so we can't go to as many teams as you do in the care and support model. But as long as there are feeders between primary care and with our teams, we're comfortable with that, and that we've got that joint working on that basis with them, and we will align closely with CNTW going forward. We did pilot this back in 2019, just before COVID kicked in the north, in the Alnwick area, and it worked really, really well. At the point we piloted it, we actually went a little bit further and tried to include occupational therapy and some other facets of the service in there. That will be something we look at again going forward, but there just isn't a big enough mass of staff in occupational therapy to spread them across 14 teams and still have cover if somebody's off sick or on leave. So we're scratching our heads a little bit to think about how we can get that level of integration with a smaller mass of staff, but as I say, not off the agenda going forward. The other thing we're looking at going forward is, at the minute, with our very kind of silo-based approach to work that we had previously, all new referrals come through Foundry House at the minute into adult social care. They all come through that front of house. We're looking to soften that going forward, and there's no point in us having a relationship with GPs and primary care if we don't allow them to refer directly into the team that they're linked into. It would be crazy for that to go through Foundry House first to then come back into the team. So there's little subtleties like that that we're just going to slowly tweak over the coming months as we go forward and kind of pick that up. We'll probably have to review the back office as well at some point. We have kind of rushed ahead with the front of house bit of it, but at the minute we still have admin teams linked to all the individual social work teams. We're thinking it may be more sensible to actually centralise those and offer that support as a core and out over model. And as I mentioned, we're looking at the other groups of staff again to see whether we can expand the teams. Our starting point from this point forward is always the service users first. What do we think is going to improve the quality of service for people who are interacting with social care, and to make that as simple as possible for them? I mean, as you will all know, at the point people come to us, they're generally in crisis. It's the worst point they've hit in their life, or they wouldn't be coming to adult social care asking for help at that point in life. It could be through a trauma, a stroke, a heart attack, a degenerative disability or whatever, mental health issues. The last thing you need is a really complicated system that you're struggling to navigate when you're vulnerable and you're in that situation. So we're just trying to simplify this as far as possible with what we're doing. I don't think it'll be ever perfect unless you could glue the whole of the NHS, social care and everything together into one team, which I doubt we'll ever get in my career and lifetime. It's not going to be perfect, but we think this is a step forward at this point, and the initial feedback's been really positive from the teams and from the interactions that we're getting from service users as well. Actually, what's been really heartening as well is some of the messages that we have had to have a reshuffle here, obviously, of caseloads. And I think sometimes just a sense check of how many people have come up and sent me messages to say they're really sorry that they're losing their existing care manager or social worker. And I feel heartily guilty about that in terms of what we're doing, where they've built up good relationships. But I think for the greater good, this direction of travel will create more of those good relationships than we've lost through this process. So, Chair, if that's okay, I'll stop there and field any queries.
Thank you. You sound really positive. That's positive report.
Trying to. Yeah.
Again, this is for us to note for information, but happy to take questions and comments. Councillor Bowman.
Thank you very much. I would say that 50% of my role as a county councillor is in this area. I've never known anything like it. I don't know if it's to do with COVID or ageing population or whatever it is, but I would say 50% of my caseload is related to care. You touched on about the end user. Will there ever come a day when the end user can actually phone up the county council direct, like a hotline number, and ask for services? Will that ever come?
Do we mean in terms of adult social care, Councillor Bowman? Yeah. So, I mean, we do have one call at the minute as the route into the council, so which is a single point of contact and a single number, and therefore that should exist now. I think what I'm actually saying is I want more than one number at the minute, and actually for us to have more direct referral routes in. I think we've oversimplified the system, but we do have that at this point in time. So.
Yeah, can I come back on that?
Councillor Bowman, sorry. Communities together would also help.
Yeah, one call is a fantastic system, but it's not advertised, as it were. It's not well known by the communities. They know their doctor's phone number, they know their hospital for emergency care and that sort of thing. But as for social care, that number's not out there. If it was, say, like a number like you got 101 for the police and 111 for the NHS, if we can get a number like that, similar.
I mean, we can certainly have a look at that. I mean, the hope would be that all the bodies that would generally refer people into us would have that. So your GPs will have that number, your hospitals will have that number, your referral points would have that number through, but we can certainly look at whether we feel there should be a more generalised thing. I mean, I suppose the difficulty is 999 and 111 are generally for emergency situations at that point. That's not to say you can't have a more urgent situation within adult social care, but generally we're about stepping in and assessing people's needs for their life going forward, you know, kind of how we support that. So, but take your point, we can certainly have a look at that and see whether we think we need to advertise it more widely. Yeah.
Thank you. Any other questions? Derry Newton.
Very much along conversations, obviously, that we have a lot of the time with members of the public. I just feel that there is still a lot of confusion or lack of knowledge at the moment about the new structures anyway within care and health services, and I just wonder how we can help, I think as Councillor Bowman was saying, help people understand that a bit better. But I suppose from our perspective as well, it's how you're going to measure the success of it. What are your plans for sort of talking to service users, getting their feedback and what measures are you setting yourselves for success, I suppose, and where can we help?
No, absolutely. And I mean, we would want Health Watch, obviously, to be involved in any feedback with that. I mean, we do annual surveys, you know, of customer experience with adult social care. I mean, we would want to anyway, but we're required to as part of national reporting back to DHSC. So, I mean, that would be an obvious starting point for us. But we want to sense check with partner organisations as well as to how that's working, as it genuinely improved the interaction. I have to say the initial feedback has been really positive from primary care. I mean, Dr. Mooney from the Valence practice and everything has been waxing lyrical about the interactions here. We did start a bit early with him ahead of the game, to be honest, back in October time, and we're in essence role modelling him out to other GPs, because GPs are a mixed bag as well. Some are buying into this more than others. They all work as independent small businesses and things like that, so that, you know, there's a little bit of working with them to try and see the benefits, and some will grab this to a greater degree than others as we go forward. But we'll be looking to sense check in with them, and I mean, our complaints data as well is very informative on where we're at. You know, I was fielding a lot of complaints on handoff, having to tell my story multiple times and things like that. So the monitoring of that data coming back through. But it would be helpful to work with the likes of yourselves as well to do some kind of focused work on that. We just need to let it bed in for a little bit first. You know, I'm probably thinking 9 to 12 months down the line to let that settle properly, to actually get people who've worked through the new system rather than, you know, at this point really where we've just flipped the switch. So, yeah.
Thank you. Any other questions? No. Okay, then thank you, Neil. We'll just move on. So the Health and Wellbeing work programme, Chris, do you want to take us through that?
Thanks, Chair. The work programme is, just to note, there is one slight change, which is the complaints annual report for adult social care. That was June, July. I've been asked if that can be deferred until October, so we've moved that just by a couple of months. It would usually come in around September, October time. I think I scheduled it a little bit early, so I've been asked to move it. That's the only thing I want to say on the work programme at the moment.
Councillor Hill, comment.
Thank you. You will have hopefully read in the paper some quite alarming allegations made by the NEAS, the ambulance service. It came up in Parliament and the government minister said that they would have an investigation. What I would suggest, if it's not already happened, is we contact them and ask what the terms of reference of the investigation and what reporting and work can we do, because obviously they're within our scope for scrutiny, and these are very serious allegations and have to emphasise allegations that come up at national level, and we should be informed and involved in the appropriate way, I would suggest.
Yeah, we'll be in contact with the department on how we can help with that review. I've already spoken to the coroner in Northumberland and will continue to speak to him, as well as Health Watch. I had a very brief conversation with Derry about that. So we'll keep an eye on what's happening and contribute where we can.
Sorry, I didn't realise. So, anything else on the work programme? No. In that case, next item is urgent business. I've not received any notification of urgent business. So the date of our next meeting is the 5th of July at 1 o'clock as usual. Thank you very much and thank you for coming. Switch off the live stream, please.